right, we will get started. Thanks everyone for joining us this morning. We're celebrating a major planning milestone with the submission of the stage 1.3 submission, formerly the stage 2 submission to the Ministry of Health. We have a presentation prepared for you this morning. David and Karen are going to talk briefly about the significance of this step, how we got to this point, what is included in the plan, and also what's next. And then we will open the floor to questions. So I will turn it over to David. Let me just make sure that we are recording this. I will also drop the media release in the chat section for all of you, and we will update that link later today with the video from this. So if anyone's looking for the recording later today, you can find it at the link that I will share in a minute. So David, over to you.
All right. Thank you, Allison, and thank you, everybody, for joining this morning. I'm David Moucher, President and CEO of Windsor Regional Hospital, and we have Karen Riddell here with us, who is our Chief Nursing Executive and Chief Operating Officer of Windsor Regional Hospital. As stated, we're going to go through a brief slide deck, just kind of update you on where we've been, what we're doing now, and where we're going with respect to the project. But as Allison stated, Friday, we pressed send and sent our stage 1.3, which is the former stage 2. We just did the change in numbers to confuse everybody. And our goal is now to move into stage 2, which is the former stage 3 process as well. So as stated by Allison, and on this slide, we're going to start from the left and move our way to the right and talk about where we've been, what we've been doing. So first is, if everyone recalls, back in October of 2021, finally, the current government, after the previous government had announced moving to stage 2 in 2017, but never flowed the money, the current government, even at the midst of a pandemic, announced we're moving to stage 2 and actually flowed the money to start that planning. So that's when we received the capital grant in October of 2021. A project management team was assembled to lead that planning at the start of the new year. And very soon thereafter, we had 40 user groups representing all program and service areas in the hospital, and they started to work on the functional program for the new hospital. And that's the detailed planning document that describes future services, activity volumes, staffing levels, new technologies, and space requirements. And in these user groups, we'll talk about a little bit later as well, is it involved not only frontline staff, physicians, clinical, non-clinical leaders, but also individuals from the community. So shortly after this work began, we invited community to meet members of the team and share ideas of the future hospital and ask questions. Information was collected throughout all of this, and we built an engagement series that's been incorporated into the planning process. And then in September of this past year, Stantec Architects was hired as the planning, design, and conformance team, or PDC team, of architects and engineers working on the project. So they got right to work with the user groups to develop a campus plan outlining where the hospital is located on the property, access points of the hospital, and things like parking. They also developed a set of block diagrams that illustrate where all the programs and services will be located in the hospital. So next slide. So what is the stage 1.3 submission? So again, as stated, it's a major planning milestone, and it shows the collaboration extensively between the many partners within the hospital and the community. Again, it provides a functional program, set of block diagrams, a campus plan, and an updated cost estimate. It is based on current and future projected volumes and incorporates the extensive community feedback received, and it requires ministry approval before we proceed to the next planning stage. So by the numbers, what does this document look like? Well, it's 1,132 pages long. It took 16 months to complete, has 40 hospital user groups involved, which again includes community members on them. And we had 13 public town halls throughout the whole 16 months to talk about getting ready to start the process and providing updates and getting feedback and using that in our planning. So it was a very exciting process with respect to this. I will now hand it off to Karen.
Thanks, David, and good morning, everyone. So the stage 1.3 submission user groups, just a little bit of detail about that. So we had 40 user groups representing all hospital programs and services that participated in this planning stage. And these groups were made up of hospital leadership, frontline staff, our professional staff, and as well as our patient representatives. Our patient representatives included members of the Hospital Patient and Family Advisory Committee, the Chief of Essex Windsor EMS, and representatives from all First Nation communities represented by the London District Chiefs Council. So very well attended, and lots of hours put into the stage of the planning. So the submission highlights for stage 1 include a 9-story inpatient tower and 5-story diagnostic and treatment block, capacity for 100% private rooms, shelled-in space for future growth, a simulation training center and auditorium, Indigenous healing space, cafeteria with access to outdoor seating, and links to city plan trails and bus service. So the estimated project timeline, stage 1 or early planning, the proposal was completed in 2017 with the functional program January to June of 2022, and the block diagrams November 22 to April 23. The detailed planning in stage 2, pending review of the stage 1.3 submission, was our indicative schematic design, our functional output specifications, procurement documents and RFQ to be released in early 2025, the RFP process and evaluation, followed by stage 3 or construction to begin in summer of 2026 with the developer selection and contract award, working drawing, a construction phase, and operational readiness and move-in. So I think I'm back over to you, David.
Thanks, Karen. So what's our next steps? So again, we pressed send on 1.3, the former stage 2 Friday that went in. So we're going to be continuing to work with the Ministry of Health Capital Branch. From my understanding, what they do is they take those 1,100 pages and they divide them up into the segments and send it out to their team, get feedback, get comments, get questions, and we'll send it back to us. We already have a meeting scheduled for the end of this month with the relevant individuals to get their initial feedback and start that process in earnest. As stated, the work continues in the other areas of planning, so we can have shovels in the ground by 2026, as outlined in the Infrastructure Ontario's November market update. I think was updated again this year already, and confirms shovels in the ground by 2026. Key priorities we do right now. So we continue to work in earnest on the OLET campus, and also development of information communication, automation, and technology vision and strategy for the new hospital. So there's active work ongoing as we continue to review stage or phase 1.3 with the ministry over the next few months. And I think that's it. And what we'll do is take questions. Allison will handle that part.
Thanks, David. So I will just go around and call upon the first person I see in order here, starting with Dave Battigello from the Windsor Star. Dave, do you have any questions? Dave, I'm not sure if you have any questions. Your mic looks like it's on, but I'm not seeing any activity there. Oh, If you want, just put it in the chat section if you do have any questions, and we'll go to AM 800 News. I believe we have Aaron Mahoney on the line. It's either a very quiet group today or everyone is having internet issues.
Audio not working.
Oh, Dave's audio is not working. Okay, so I think he did type in a question here.
Latest cost estimate. Figured everyone would ask that. So it's very preliminary numbers. We are not privy to release them. We have to share them with the ministry first, and the ministry has to review them. And then there'll be a process shortly thereafter with respect to those discussions. But again, when it comes to initial quote cost estimates, what it does is it forecasts out into the future based upon current inflation rates that we're dealing with now, plus what projected. So the number clearly is higher than what we estimated years ago with respect to that. So, but the exact number is that will be released possibly in generalities into the future. You have to respect also the issue of, you know, if you're going through a tendering process, you don't want to give an exact detailed number at the advance of a tendering process, because guess what? That's going to be the result during the tendering process. So that's going to pretty much set a floor. So I can indicate, as I've indicated already publicly, is the number that is being bounced around. But again, it's so tentative, is larger than what we had previously estimated, just because of inflation and because of supply chain issues, and because it's been so long since this project was first envisioned and when the first cost estimates came forward. But again, when we're in a position to be able to give some general numbers, we will. It's just a little too early, and we don't want to set it off into one course or the other. But definitely it's higher.
And I see we have a AM 800 also having weird audio. My question would be, when do you expect to hear approval for the ministry on the most recent submission?
Again, we're having meetings with them as early as this month. They recognize that there's a timeline we have to meet, that being go to tender in 2025, shovels in the ground 2026. We have a lot of work to be done before then, especially with respect to detailed drawings, which will form the basis for the RFP. And when we talk about detailed drawings, those are like room by room by room. Right now we have block drawings. So we'll say, you know, you've seen them on the town halls, critical care is this area, and it shows rooms, but we're going to now dig in, go room by room by room, exactly what they're going to look like, every single room in the hospital. So we're hoping over the next few months that we will get formal approval to move into the next stage. What that next stage exactly looks like could morph a bit, because they're looking at different ways of working with a general contractor and engaging them a little more earlier in the process, what they've done with other hospital projects that are right in front of us in the province, that being Trillium or Ottawa. And we're going to see if we're going to move towards that type of process, or we're going to be more in the normal formalized process, which is wait in 2025, go to tender. So it could morph a bit over the next few months on which avenue the ministry and the government wants to take us on proceeding. But the bottom line is we got to get ready for RFP in 2025 and shovels in the ground 2026. So we hit our target in getting 1.3 to the government in April. We set that target months ago, and now we're looking to work with the ministry and the government on moving this project forward.
We will go now to Kathleen Saylor from CBC Windsor. In the meantime, though, Dave and Aaron, if you have any follow-up questions, please type them in the chat, and we'll see if Kathleen has any more luck here.
Hi there, can you hear me okay?
All good.
Awesome. I guess I'm wondering, now that we've reached this critical milestone in the project, how well does this phase of the hospital represent your wish list, or like your ideal hospital? Did we get everything in this phase that we wanted?
Yeah, great question. And what we've kind of warned everybody is that's the work that needs to be done. And from my understanding, actually, is even when you work with the general contractor, things could change, meaning the general contractor might look at all of this and come up with ideas that could make things more efficient in the construction project and save monies, but not change the ultimate result. So yes, that's what we got to look at right now and work with the ministry. And as Karen indicated, we've populated what's called, rough-in space. So what happened is, during this pandemic, we had to go to the St. Clair Sportsplex to find a field hospital. We didn't have any additional physical space to the degree we needed it within the existing structures in order to support that. Other organizations like Oakville, which recently built a new hospital, had this shelled-in space. So when it came to them needing a field hospital, is they built it right within their own four walls, and they were able to expand. So that's what we want to get approval on. Whether that's approved or not, that's still work to be done, but we've planned for that. And it's in the drawings we've submitted. It's in the design. It's whether the ministry will support it. Hopefully, I'm confident that based upon what we went through during the pandemic, is having this shelled-in space has clearly more credence now than maybe it did in 2019. If we were having these discussions with the ministry in 2019, what we all lived through for the last 3 or 4 years clearly indicates we need to have this excess space. And when it means shelled in, it means it's ready to go. It's not operational, but it's weeks away from operation as compared to, as we stated, using something like the St. Clair Sportsplex for a field hospital. So in general, what we're going to end up with is going to be very similar to what we have. But yes, there could be changes, and that's part of the planning process with the ministry, is having those discussions on, from their point of view, what they will support, and working on that. But I don't know, Karen, if you can talk about maybe the groups and their excitement with the work that was done, and even the community members on the committees, on the user group.
Yeah, absolutely. And a lot of the work that the user groups did was really around access and adjacencies, and making sure that we had the shortest walking distance for our patients in the community to get to the services that they would need. The shortest routes for our sickest patients to get from the emergency to the OR to the critical care areas, and really ensuring that each of the clinical areas really has a therapeutic environment. So they've got access to open spaces, all have windows, there are courtyards, there are park areas. So these are some of the key things that really contribute to that healing environment that we want to have in this new facility. So there has been a lot of excitement. We deal with some significant infrastructure challenges now. When you think about, for example, how far our cath lab is from the emergency department, from our critical care areas, and how we can correct those key adjacencies moving forward into this new hospital. So that's just one example of the things that we can correct into the future for our community. So really exciting work.
Yeah, and just before you jump, because Kathleen, you twigged on a great question, is also with the design we have now, and hopefully it maintains itself, is what we clearly tried to do, as Karen indicated, is generally when people come into the hospital, they come in for a particular service. So they don't, luckily, taste every single service in the hospital or experience it in one visit. So what I'm trying to get at is, if you come in for an outpatient diagnostic exam, so you come in for an MRI or CT, that's what you're coming in for. So if you look at the way the current hospitals are structured and built, is you got to pretty much walk, especially Met, you got to zigzag your way through the whole hospital to get a CT. You definitely have to zigzag your way through the whole hospital to get an MRI. You sometimes, if you're lucky enough to get access to the cancer center parking lot, otherwise you got to park out in front and lens and walk a city block to get to the cancer center. So the goal is to have those, number one, adjacencies, but also to have those dedicated entrances. So you go to the cancer center, 90+% of our patients go into the cancer center, get their treatment and leave. They don't go, in addition, some do, but very few go to an inpatient unit the same day. If you go in for, as I stated, a diagnostic exam, a CT or an MRI from your home, you come in, get it, you leave. Emergency department, 85–90% of our patients are not admitted. You go into the emergency department, you leave. So, and if you need access to the inpatient unit, there's a dedicated entrance to get to the inpatient unit to visit a loved one, etc. So that's the way we've laid out the hospital, is to take advantage of that, so individuals don't have to walk through all these other areas to get to the area they need to, like we do now. So basically, you can drive up to your particular area. You have dedicated access, dedicated parking to that particular area. You can go in, take as few steps as you have to, and leave. Now, we know when we open the doors, we'll have a lot of people just come in to take a visit and walk around. So we're planning for things like, into the future, where before we open the doors, we'll open up to the community just to walk around and look at everything to avoid that. So we don't have thousands of people coming the first day just wanting to look around the place, and we can focus on patient care. So those are some of the exciting things coming, but so hopefully, Kathleen, the way we laid it out is to take advantage of that and really be patient focused and staff focused to that extent too, because staff generally, if they work in an area, that's the area they work in. There are some that travel the whole hospital, but very few. They go to a particular area on a particular day, and that's where they work.
Great, thank you.
Next up, we have Maureen Rive from Blackburn.
Hi, can you hear me okay?
Yep.
We can.
Okay. You mentioned it in the beginning. I know this phase of submission has focused on the new hospital site. Where is planning for the OLET site? Is that part of this approval process?
Yes, so that's what we're working on extensively right now. We have, of course, the preliminary ideas with respect to the programs and services that will go there. So that's the work we're starting as we speak, is the user groups now, the same user groups that will have services and programs at OLET will now focus on OLET and get this work done. We have to remember the timing of all of this is the new hospital has to go to tender and construction as stated in 25-26 shovel in the ground. We will not be transitioning out of OLET until the new construction for the new facility is done. So if you want to say we have a little more time to deal with OLET, and that's why we're focusing on new acute, that's got to go first. Do the OLET work right now, which is less extensive, but has its infrastructure issues, which we have to deal with, and present that to the ministry. So over the next few months, we will be getting the OLET 1.3 done and submitting that to the government as well. And they will run in parallel, but again, new acute needs to go first. OLET has, in effect, the time it's going to take to construct the new acute before we can move those services from OLET over to the new acute. So hopefully that makes sense, Maureen.
It does. Is the budget that the province will be approving, does that include the OLET plan and build?
So from our understanding, is OLET's going to be a separate contract from the new acute because hopefully the cost of it is not going to be clearly as extensive as a new acute. So it's going to be segregated from the new acute. And so when it goes out to bid, the contractor is going to be bidding on the new acute, And then we'll have a separate contract for whatever has to be done at Olette.
Is there a placeholder though already, like that is construction is included in this whole process? I'm just making sure, confirming, 'cause I know people are going to start saying, well,
Yeah.
if you're not submitting plans for the Olette, then,
No, we are,
is it part of it?
Yeah, so just make it clear we are. It's just getting the work done. And also, from a process point of view, we got to make sure we understand what's going into the new acute. And then we work on Olette as well. So the plans are going to be in. Yes, what we're being told, again, they don't tell us we've set aside X amount of billions of dollars for you, except maybe on that IO chart, it says greater than $1 billion. So that could be, 10 billion, who knows? So, but yes, we're being told that they recognize there is going to be some cost to Olette, but again, that's left to be seen what that cost looks like, because we got to do that work, and you really don't know the cost till you go to tender on the design. So, but yes, they totally recognize as part of this overall project is there's not only a new acute cost, there's an Olette cost, plus you got to remember hotel dues working on TAFOR, there's a TAFOR cost, and they have those pockets. But they don't tell us we've set aside X amount of dollars. We don't know the dollars they've set aside. Does that help?
Thank you.
All right.
Thanks. And last here we have John L., I believe John Lewis from CTV.
Yeah, sorry, no questions. Thank you.
All right. Well, unless anybody has any follow-up questions,
That's you in the chat. Sorry.
I just put our website in there, plugging it. If you have any additional questions or want more information, as always, it's available on our website, windsorhospitals.ca. And again, I'll post this later today to the news link, and we'll keep you updated as we move through this process. It's been exciting, and thanks all for joining us this morning.
Thanks, everybody. Enjoy your day.
Thanks, everybody. Bye-bye.
Bye-bye.
Thank you.